welcome to the Ready Set Baby virtual class. I am Robin Hubbard and I'm one of the doctors at Grand Rapids Women's Health, and we're so glad that you are able to join us. All of the doctors at Grand Rapids Women's Health are really grateful that you chose us and our practice to help you during this most exciting time in your life when you are expecting a new baby into your family. So please join on. We've tried to make this video as user-friendly as possible with some links to different parts, and to try to give you as much information as you can. We have videos of a little hospital tour and some tidbits since we're all homebound right now and can't get out to do all the classes that you normally would do. So let's move right along. The first slide, we're going to talk about a few reminders. So the first thing I want to just bring up is, do you know where to go? Spectrum Health is where we do our deliveries. So that would be Spectrum Butterworth, and that is located on 100 Michigan. You do not go through the emergency room entrance. You're going to enter on the back side. So on the A level, where Ransom Road meets Crescent, you follow the signs to Women's Center or Maternity Admitting. It's one of the few entrances open right now. And so you go to the back and follow those signs, and it says employee entrance only. Don't mind that, just go right in. You can park in ramp 6 and you show up right there. There are maps available in the office if you need any further assistance. We'll try to attach one to this video so you have some further instructions. Number 2, have you chosen your baby's doctor yet? So it's a good time to do some research and find out about pediatricians. We do have a list of pediatricians that we can include. Some offices will allow you to ask some questions of them, and really the most important question is, are you taking new babies? So if a pediatrics office is taking new babies, you don't have to have any other contract, appointment, schedule. Once the baby is born, we contact that office, and then they either come to the hospital to do the first newborn examination the morning after your baby is born, or the hospital pediatricians will do that on behalf of your doctor, and you'll follow up with a pediatrician visit after that. So try to line up some pediatricians. There's lots and lots of good offices in town. Later on in the office, a pediatrician will give you a little blurb on pediatric care, and you can learn more about that. So that's something for your checklist. So the slide that we usually use for this class was pre-COVID and talked about signing up for prenatal classes. Hopefully this will help to bridge that gap. There are some online resources available that you can look in for some prenatal classes. If you want to look into some breathing classes, spectrumhealth.org offers you some of their prenatal classes. And then there's also other classes that you could find throughout the internet. And so if you are interested, please do some searching, and certainly you can educate yourself. The What to Expect books and other good resources. I really recommend that you use resources that end in .edu or .org so that you can find reputable resources and not follow along a little path that might take you down some scary site that makes you alarmed or frightened. Do you want a tour of the family birthplace? That is a part of this video. Aren't you lucky? So Dr. Hoekstra was on call the other day, and she filmed some video clips of a tour of the hospital for you, so you don't have to do it right now while you are sheltering in place at your home. And she's going to show you some highlights of the hospital at Spectrum so that you feel comfortable and familiar with where you will be when you have your baby. Are your bags packed? So a good idea in the last month, maybe from 36 weeks on, to have a bag packed. Spectrum Health's website has some tips and pointers on what to pack. There's also lots and lots of resources in your books and online and pregnancy websites on what to take to the hospital. Truly, if you drove your car there with nothing, we have everything that really you need, but just things for your comfort. Your favorite fluffy robe, your favorite slippers, your favorite lip balm, maybe a really good speaker that goes to your phone with your best playlist ever. Those things might be really helpful to have. And otherwise, we have a lot of great things for you. So pack your bag, but don't overdo it. Just a tip, and we will get into this a little bit later, but right now with the visitors that are available, you are going to stay in the room, so moms and your partners will be in the room the whole time, so if you want special snacks or drinks, you might want to pack those too. Have you purchased a car seat? Car seat's really important. You can't leave the hospital without it, and we'll have a little section later in this video on car seat safety and how to do that, but it's a good idea to be researching car seats. I know it's hard because you can't go shopping, but you certainly can order online, and having a car seat is a really important first step, so do a little research on newborn car seats. So that is our reminders. And then we're going to talk a little bit about COVID. So what's on everybody's mind? I know that COVID is the first thing on everybody's mind. We've never lived through a pandemic before, and certainly it is anxiety-provoking for everybody. And I just want to reassure you that your doctors at Grand Rapids Women's Health and all of the care staff at Spectrum Health are doing everything they can to make this experience for you as safe as possible. So every single day there are meetings and discussions and planning going on for us to be prepared for what may be or may not be the inevitability of a rise in cases of COVID-19, and how we in Grand Rapids are going to be prepared to take care of our patients. And so just be assured that the hospital is still the safest place to have your baby, and that we are prepared to take care of you in the best way that we can, and we've made just a ton of provisions. I am a part of leadership at the hospital, and there are hours of phone calls every day that we're doing virtually to meet together and strategize and make plans for you so that you're safe. So the most important thing that you need to know is what everybody is talking about, and please just listen and be the voice of reason to your friends and family. Stay home. Don't go out and meet with other people. There's no reason that you need to be mixing with friends and family. Your little home and people in it are the only people you need. Wash your hands frequently and don't touch your face. So lots of people have asked me, should I be wearing a mask when I go out? I don't think it's a bad idea. If you have access to a mask, if you've made one, or you know somebody that made one for you, or if you have a mask from your toolbox or somewhere you had access to one, certainly don't steal one from a healthcare worker, but it's okay to wear a mask when you go out to the grocery store. Now, some things to keep in mind: if you are taking it on and off and on and off and on and off and dropping it down and carrying it down here, it's not protecting you, and each time you touch it and touch your face, you're running the risk of contaminating yourself. So if you're going to put it on, you don't touch it. When you're ready to take it off, you wash your hands first, and then you wash your hands again, and then you either throw the mask out or you put it in a paper bag and put it on again with washing your hands on and off. So that's really important. But I really want you to be protected. For those families that have children at home that are going to need somebody to take care of your kids when you come in to have your baby, that's a really challenging issue. And so make sure that whoever is on standby to take care of your kids that are coming into your home are fairly low risk for COVID. We are doing everything we can to have you come to the hospital and be as safe as you can, but you're going out of your house and you're coming in contact with other people. And so when you go home, you should be considered a little higher risk, and for 2 weeks you should feel like you need to quarantine. And so grandparents, aunts and uncles that are perhaps older or immune compromised in some way maybe are not the best people to come in contact with you after you return from the hospital with your newborn. And while that's really, really hard to think about, not having everybody meet and share in the joy that you're about to have, it is also really important. I know one of the nurse midwives from the hospital just had a baby, and her parents drove 2 hours to come see the baby through the window, and then they went home. And these are just remarkable times, but we need to keep everybody safe, and that's something for you to really think through with your family and make sure that you're making really good choices about that. So that is my initiation talk about COVID safety. The next thing I'd like to talk a little bit about is just some COVID things about pregnant moms and babies. So a lot of women have asked me when they come to their visits, or we've spoken on the phone, about what the risks are to moms and babies in pregnancy. And we have done as much research and looking as we can based on China, Italy, and parts of the U.S. that are ahead of us, like Washington, New York, and even Detroit. And what we have learned so far is that it does not appear that pregnant women are at greater risk of complications or other issues with COVID-19, which is good news because influenza does carry higher risk. However, COVID-19 is still a very serious disease, and so none of us wants to get it. So pregnant women are not at greater risk. There have also not been reported cases in the literature or that we're aware of COVID-19 being passed from an infected mom to a baby while in utero, so through the placenta. Babies have not been born carrying the virus. But those studies are ongoing and our numbers are small. The virus has only been in existence since January. We still are learning, and we're always erring on the side of caution with moms and babies. So that is the thing that is important for you to know. When you come to the hospital to have your baby, we still think it's safest for you to be in the safety of the hospital. Home births are something that are being talked about a lot, but there are so many things that could happen at home, and we think that the safety of the hospital is still in your best interest. We've done many things to reduce the exposures that you'll have at the hospital in terms of the number of people that you see, the environment that you're in, and we're trying to get you out of the hospital as quickly as possible. So we do believe that it's the safest place for you to be, to have your baby there. I do think that protecting you and protecting the staff is really important. So if you or your partner, we are letting your partner come with you, you're allowed to have one visitor. And this is a change from the rest of the hospital. So only pediatrics and maternity are allowed to have a visitor in the hospital, and this is very strict for everyone's protection. So you can have a partner come with you to your maternity visit if you are going to be in labor. That person needs to come with you when you arrive and stay with you the entire time. They may not leave the room. They can order food service through the cafeteria, and Spectrum's food is not too bad. Nurses can bring you drinks, beverages, not that kind of drink, but beverages to keep you hydrated, and we have a nice so comfortable couch and blankets and pillows, etc. So you can stay together. Grandparents and children are not able to come, but you certainly can FaceTime and be connected in that way. I do think that this is working well for people, and most people have been very understanding. That allows us to be safe. Now, having said that, if somebody is sick, we need to know. Please let us know if you've had a fever, a cough, shortness of breath, any signs of COVID when you present, so that we can make sure that you and our staff are safe, and we can put a mask on you or your significant other, and the coworkers that are taking care of you can be as protected as possible. What happens if you get COVID and you're pregnant? It's definitely a possibility, especially if our community sees the surge that is happening in other cities. If you were to get COVID-19, we are prepared. We have looked at the data. We know how to take care of you. We have the support, the specialists, etc. And so we will do our very best to care for you and your baby. Should that occur, the hospital has done a lot of research to look into how to do that. So please let us know if you're having symptoms, primarily the fever and the shortness of breath or the cough. SpectrumHealth.org has a lot of information, community resources. All you have to do is look that up and go to the COVID-19 sites, and there is lots and lots of information for your education. Okay. We're going to talk a little bit about normal pregnancy. So the third trimester of pregnancy is starting at 28 weeks, continues on until you have the baby. Your due date is 40 weeks. Now that's from the first day of your last period, and that is just a guess. So only 5% of people deliver on their actual due date. About 40% of people go past their due date, so keep that in the back of your mind that you might actually go past. And the rest of people go before. So the birth of your baby might seem like an anxiety-provoking time. Your body starts to really grow, and you start getting a lot heavier and more uncomfortable. Pelvic floor, your pubic bone, your hips start to get a lot more uncomfortable. It's harder to get in and out of bed. It's harder to sleep. And so there's a lot of things that make this time physically a little more strenuous, but more exciting and a little more anxiety provoking as you get closer to having your baby. So it's really important that you just continue to take good care of yourself. And I know in a stressful time like this, when we're homebound, it's easy to fall into bad habits like Netflix and cookies, but that's okay to do that. But make sure that you're still trying to exercise however you can do that. A pregnancy yoga class in front of your couch. Get out on a nice day like today and take a walk. Drink lots of water. Eat good, balanced food, lots of greens, lots of protein, so that you're really taking care of yourself. Try to limit your caffeine, limit your alcohol. Please don't drink or start bad habits just because you're anxious. If you're struggling emotionally or with any of those issues, please reach out to us. We are all there to help. And certainly there's a lot of increased anxiety during this time. So the office visits start to increase as you move into the third trimester, and typically we would start to see you now every other week, and at 36 weeks we would start to see you weekly. What we've done with COVID is we've modified visits a little bit to decrease the amount of time that you need to leave your home and come into the office. What we're doing at Grand Rapids Women's Health is we are screening people at the door and asking that you not bring a visitor to the office. So we are allowing visitors for the new OB visit and for the 20-week ultrasound at this time. But for other visits, if you could have your visitor please stay in the car and wait for you, just to limit exposures to other people in the office and to our staff, and for us to you as well. That would be really appreciated. Also, you are welcome to FaceTime anytime you would like, so that we can include your partner in the process. So what we do with those visits is, as you know, your weight and your urine, blood pressure, listen to the baby, and what we're trying to do now is maybe reduce the frequency of tests. So each person is a little individual, but we're going to try to do a 28-week visit where we can do the glucose testing, the Tdap test, which is the vaccination that includes tetanus, diphtheria, and whooping cough. Whooping cough or pertussis is really important to give the vaccine to the mom so that antibodies can be developed that pass to the baby so the baby can be protected. And even though all we're thinking about right now is COVID, whooping cough is still out there, and I have heard of people recently who have become infected, and babies can be very sick or even die from it. So it's important to think about other diseases and use the protections that we have and vaccinate you. So we're going to reduce your visits. You might be seen at 28 weeks and then again at 32 weeks. Skip that 30-week visit and then see you again at 36 weeks. Skip the 34-week visit. That's assuming that you have an uncomplicated pregnancy and we don't have other concerns. And so you might discuss that with your doctor. We also have the capability of doing virtual visits where we can talk with you on the phone. So if you have any concerns, don't be afraid to do that. Some of the other common tests during the third trimester, the non-stress test. This is where you sit in the lazy boy in one of the rooms in our office with the monitors on your belly, one that records the contractions and one that records the baby's heartbeat. And it shows us just a reassuring pattern with your baby's heartbeat to make sure that everything looks good. Some people that are a little higher risk, maybe gestational diabetes or hypertension, high blood pressure, or other conditions may prompt us to do a non-stress test. If you go past your due date, we might choose to do a non-stress test. So that's something that may occur in the office at some point later in your third trimester. A Group B strep test. Group B strep is a bacteria that grows in the vagina. It just is a normal bacteria that many women have. Up to 1 in 4 of us have it there. We don't know about it. Doesn't bother us. But babies can get sick as they pass through the birth canal. And so we screen everybody around 36 weeks for this to see if they carry it. Just a tiny little swab that goes in the vagina and near your bottom. If it comes back positive, that's not a big deal. But in labor, we do give you antibiotics, which protects the baby from picking it up as they come out through the delivery. Repeat HIV testing. The state of Michigan does encourage us to repeat HIV and syphilis testing at the blood test at 26 to 28 weeks, and that is just because of trying to catch any at-risk people. It's very hard when we're sitting here thinking, oh my gosh, I'm not at risk, I don't have HIV, but there are babies that have been born with HIV and that is completely preventable, and so they do recommend that we order that screening as well. Sometimes ultrasounds are repeated at this point in the third trimester of pregnancy just for an indication. So most moms will have one ultrasound at 20 weeks of pregnancy or thereabouts to look for anatomy, And later on in pregnancy, there may be a reason to continue to follow for growth, looking at the measurements of the baby, or to follow up a placenta location, fluid level, etc. And so that may be something that your doctor orders for you. Discomforts during the third trimester. So lots of things become more common. We talked about that a little bit. We talked about difficult sleeping. Backache, very common. So there are back stretches. I know there's a sheet that you got in the blue bag at the very beginning of your pregnancy that goes over some of the back exercises. Again, those prenatal yoga classes that you can find on YouTube are really helpful. Try to get some stretching done. Don't just sit on the couch all day, even though we're stuck at home. Constipation is more common, and you can do a good job with your fiber and your diet. Eat some prunes, drink your coffee, decaf. But you can also use Miralax regularly. You can use stool softeners, and you can add a fiber supplement like Benefiber or Metamucil. Those things are absolutely safe in pregnancy, and you can use them on a regular basis. This is a problem that's super common for pregnant women. Heartburn is also common, and so it is a normal thing. Your stomach empties 4 times more slowly in pregnancy, so it takes like 8 hours for the food that you eat to empty out of your stomach, whereas when you're not pregnant, it takes about 2 hours. So because of that, it can just sit there and it wants to come back up, especially when we lay down at night to go to bed. So Tums are fine. You can take Tums. They're also a good source of calcium, which is important. But if that doesn't work, Pepcid, Prilosec are fine for you to take as well. If that doesn't work, go ahead and talk with your doctor. You can take those every day. Hemorrhoids, something that people don't like to talk about, but it's not an unusual thing with pregnancy. You can get witch hazel pads under the trade name Tux. You can use over-the-counter creams. The most important thing is to try to avoid constipation. If you do struggle with hemorrhoids and you're not finding improvement with the over-the-counter creams, talk to your doctor. There's some prescription things that we can do to help you. And then having the baby is the best thing. So once you deliver, hopefully they will get better. Leg cramps are also really common. So you might get some leg cramps that you haven't felt since you were maybe like high school athlete or something. Leg cramps in pregnancy are really common. A couple of things to think about. Are you getting enough calcium in your diet? Make sure you're drinking milk or some kind of a calcium source. Those Tums might be a good idea. You can add some magnesium, maybe a little bit, 500 milligrams a day. Potassium, if you like bananas, have a banana every day. That's an easy way to do it. Make sure you're drinking plenty of water. And then you can gently stretch your calves. You don't want to aggressively stretch them because, you'll get a calf cramp right away. They might not go away, but that's something to think about that might be able to reduce the risk of calf cramps. Nasal congestion or nosebleeds, another weird but very common side effect of pregnancy. So you just feel stuffy all the time, like you've got this mucosal swelling that makes you feel stuffy, and more frequent nosebleeds because your blood vessels are more dilated. That is totally normal. Tuck your nose up, put some pressure on there. If you have a nosebleed that doesn't stop, then you might need to go to a med center for that, but try to prevent it because we don't really want you going out and interacting with the public right now with the COVID situation. Varicose veins are also really common. Support hose might be helpful. You can get those usually through a durable healthcare place. You can order them online through a pharmacy, and that might be really helpful. You can talk with your doctor about that. And then just swelling. It's normal to get some swelling down by your ankles, sometimes in your hands. Rings might be fitting a little more tightly. I do think it's a good idea to take off your wedding rings or whatever rings you like to wear before you go to bed, because it might you might swell up a little bit and you don't want to get them stuck. A little bit of swelling is normal. Again, reduce the salt in your diet and drink lots of water. If it's getting really bad, let us know at your visit and we can talk about other strategies. And that's one of the reasons why we see you in the office, to keep checking for your blood pressure and other symptoms. In its worst case, swelling can be a sign of preeclampsia, but by far the majority of people with swelling in pregnancy just have swelling in pregnancy. And I hope that our weather keeps getting nicer and nicer, and if we get a nice warm hot day and you go out for a walk, you might get some swelling, and that's really normal. Stress incontinence. So stress incontinence is one of those things where you can leak urine just with a cough or a sneeze or a lift of a baby or a bag of groceries, and that is not that unusual with a baby. It doesn't mean that you are going to have it happen after you deliver, although it could. Some things to think about. The baby is sitting right there on your bladder, and especially in the third trimester when the baby is more likely to flip over and be head down where the head is pushing right there on the bladder next to the pubic bone, there can be so much pressure that your poor little sphincter just can't control it and you might leak a little bit. It is okay. Think about doing your Kegel exercises where you tighten those muscles to try to increase the strength of your sphincter and help control that a little bit. Don't worry. If you need to go to the bathroom more frequently, go. I know a lot of pregnant women feel like that's all they do is go to the bathroom, and then when they go, it's like a teeny little amount. Totally fine. It might be an early sign of urine infection. Probably not just if you leak, but if you have any symptoms that are changing, burning, urgency, frequency, let us know so that we can check for infection. When you come to the office and we're dipping your urine, we're looking for protein, which is a sign of preeclampsia, and glucose, which is a sign of diabetes. We're not checking for infection routinely, so if you have any indication that you might have an infection, let us know. That'd be important to know. If stress incontinence doesn't get better after you deliver your baby within about 6 weeks, please let your doctor know. There's stuff that we can do to help you. That's pretty straightforward. Okay, moving on to travel. So travel in pregnancy, of course, right now what I'm going to tell you is with the COVID and the stay-at-home orders, I really hope that you're not traveling. If for some reason you do need to travel, you're an essential worker, you need to go to work, then obviously use safety. We want you to use a seatbelt, and you use the lower strap below your belly. The shoulder strap goes above your pregnant bump. If you're in a car accident, please call and let us know. If you fall down the stairs, hit your belly for some reason, please call and let us know. There are sometimes extra things that we do, especially in the third trimester, to monitor you and your baby so that we can make sure that everything is safe. But I really don't want to address some of the things that we normally talk about. Long car rides, I just don't encourage you to be doing at all. I want you to stay home. I don't want you to visiting people. I don't want you going far away. Any place where you have to drive that you have to stop at a rest stop and use a public restroom exposes you to potential COVID risk, and I don't want you doing that. That covers the next slide as well, travel during the third trimester, where we cover air travel. Those were the days, right? So I really don't encourage air travel. I think it's unnecessary exposure, and we need to be staying home right now. And hopefully after the COVID pandemic is over, we'll be able to fly and take your baby to meet the family and friends and enjoy the travel that we have missed out on now. Kick counts. So kick counts in the third trimester are something that you can do just to follow your baby. So I'm sure that you can feel the baby kicking and punching and moving. A lot of people feel like the peak movement is between 30 and 31 weeks. So baby neurologically is developed enough that they can be pretty wild in there. Sometimes you can just see your belly moving and shaking. After that, babies feel like they might slow down a little bit. And I never want your baby to stop moving, but they might get just a little more squirmy because they get big enough that they're so crowded in there that they can't quite do the punching and kicking that they once did. So kick counts are a way for you to just touch base. Keep in mind that babies can sleep for about 90 minutes at a time, and so napping is totally fine. Within that time frame, I'm not worried. But if you've got a half a day period where you think, gosh, my baby just is not doing its normal thing. Usually, every morning, baby's really active right about now, and it's not doing that, then absolutely touch base and try to do a kick count. What I recommend is that you eat or drink something that might stimulate the baby. Ice water, maybe something with a little sugar, a little caffeine. Lie on your left side and focus just on the baby. This is not a time for multitasking. Every movement, a roll, a punch, a kick is a movement. So you should get 5 movements within an hour. Usually, if the baby is moving, you can do that in 5 minutes. And then you know everything's fine. If you don't panic, but please feel free to call us and let us know that you're having some decreased movement, and we can easily increase the way that we're surveying the baby, have you come in for a non-stress test to make sure that everything's okay. I never really want the baby to stop moving. Having said that, sometimes when you're really busy at work and you're distracted, you're not feeling the baby move, that's okay. On your break or right after work, touch base and connect so that you know that you have assessed what's going on with the baby. And again, never be afraid to call us if you have any concerns or questions. Okay, so general pregnancy warning signs. Please call the office if you notice any of the following things. So if you notice vaginal bleeding, that requires you to wear a pad. So a little tiny bit of spotting is okay, especially if that follows intercourse, an unusual episode of lifting, something like that. I'm not super worried. But if you have heavier bleeding that requires you to wear a pad, please let us know so that we can evaluate what's going on. If you have a fever above 100.4, especially right now, that would be a sign of infection or COVID, a new cough, a new shortness of breath. If you experience pain or burning with urination, which can be a sign of urinary tract infection, and if you have sudden swelling in your face, hands, or feet. Now, mild swelling is okay, but sudden dramatic swelling could be a sign of preeclampsia, and we would want you to let us know. If you have problems with your vision, this is usually spots or flashing lights. So if you're seeing stars or flashing lights, not just floaters, please call and let us know. Or severe headaches that won't go away with Tylenol, please call. Again, those are symptoms of preeclampsia, and we would want to know. One of the reasons why we have you come in and check your blood pressure and dip your urine each time that you're in our office. Signs of preterm labor. So preterm labor is contractions leading to cervical change before 37 weeks of labor. Term is considered 37 to 42 weeks of labor, although we really like babies to be born at 39 weeks to 41 weeks. That seems to be the very best, most healthy time for babies. 37 is considered term. So if you feel like you're having contractions before then we want to know. How do you know? Because some people start having contractions or Braxton Hicks contractions as early as 20 weeks. So at 20 weeks, you might notice a little tightening or squeezing or pressure where you feel like your uterus is getting a little bit hard, and that might be really called a Braxton Hicks. But if you notice regular or frequent contractions that are occurring, then we want you to call us. What I tell people is if you're having tightness that is occurring across your whole belly, that's happening 6 times in an hour or more, that doesn't go away after you lay down and put your feet up and drink a big glass of water, then call us. So the first thing I'm going to do if you call me is tell you to lay down and drink water and call me back in an hour. So try that first. And a lot of times it's just that. You overdid, you got kind of dehydrated, you were super busy at work, you were busy with the kids. But if that doesn't work, please call. So use the 6 an hour for contractions. If you don't know what to feel in your belly, I like this model somebody told me a long time ago. A soft uterus usually feels like this, a mild contraction usually feels like this, and a hard contraction feels like this. So if your uterus is really tight, like in labor, your whole belly is going to get so tight that it feels like this. Hard to imagine right now, but occasionally when the baby's moving around, you can feel the head or the butt, and you almost get that sensation. Sometimes it's even hard to tell the difference between what's the baby and what's a tightness. And so let me know. Some of the things that can go along with preterm labor, aside from contractions, might be abdominal cramping, kind of like menstrual cramps, and diarrhea, sudden severe abdominal pain, regular contractions, or if your water breaks. And sometimes that's really obvious. You hear a pop and there's a gush of water everywhere, and sometimes it's not so obvious, where your underwear are wet and you think, oh my gosh, did I just pee my pants? I don't know, but I changed my underwear and they were wet again, and it doesn't smell like urine, and I'm not really sure. Ever, if there's a question about that, please call. Even if you're not having contractions, sometimes your water could break and we wouldn't know. So those are the preterm things that we would be concerned about and want you to call our office anytime, day or night. There's always one of the doctors on call ready to answer your questions. So, common normal signs of pre-labor. So what might happen as you get closer after 37 weeks? You might notice a little bit more contractions, lightening, release of your mucus plug. So lightening is just when the baby drops down lower and you feel way more pressure down on your pubic bone and on your bladder, and maybe even a little bit of relief from your diaphragm. You feel like you can breathe a little easier, maybe more room where your stomach is, but a lot more pressure down lower, and that can be the baby dropping. I swear there are people out in the community that think that they can tell every single pregnant woman and whether the baby's dropped, and I've been doing this for 23 years and I still can't tell. So I don't know, some people feel like they need to know if their baby's dropped, and you might not ever know until the baby comes out. Release of the mucus plug. Mucus plug may come. It is it's like very thick, sticky mucus. There might be a hint of blood in it. It might be a sign of labor, it might not be. And you don't have to call us for that. It kind of looks like you blew your nose in your pants. I know that sounds gross, but that's kind of what it looks like. So that is just something that may happen. There's more to come, like a little one can come out now and more can follow a week from now. Unless there's contractions or your water breaks, you don't have to call to let us know about that. Other signs, you might feel like you're nesting, like cleaning under the refrigerator, cleaning out the lint trap on your dryer. We're probably all doing that right now, right? We've been homebound for weeks. You might notice a little bit of weight loss, increased backaches, diarrhea. So those things can go along with labor, but we're really, really looking for the contractions and the breaking of the water. Although only 10 to 15% of the time does your water break first. So the contractions is the big one. So how do you know if the contractions are really, really labor contractions? So there's a little graph on the slide that talks about Braxton Hicks contractions, where there's a segment of the uterus, just a part of the uterus that contracts, a little piece where it kind of gets hard. This is what's been going on since maybe as early as 20 weeks, where a little part of the uterus gets tight. It doesn't really cause back pain. It's not the whole uterus. There's not a rhythmic contract pattern to it usually, and that doesn't change your cervix. They just come and go. True labor contractions will wash over the whole uterus. Often they'll start in the back, they'll sweep over the whole front, the whole thing will get tight, and they come and go on a very rhythmic pattern. And so what we're looking for is that to occur every 5 minutes or closer, from the beginning of one to the beginning of the next one, and to last at least a minute, usually to the point of being painful enough that you really can't talk with it. I can tell when I talk to people on the phone, when they call me, when they say that they think they're in labor, if you're like, oh my gosh, I'm having contractions, they're every 5 minutes, and I'm so excited because I've been really excited to have my baby, and I think this is it, and I'm having one right now, I'm like, oh yeah, you need to stay home a little bit longer. But if you're like, oh my gosh, I'm having one, honey, you need to take the phone because I'm getting one, I think, oh yeah, you need to go to the hospital. So I can tell just by the tone in your voice that the intensity of contractions is there. And then once they're 5 minutes apart and that level of intensity, it's good to stay home if it's your first baby for about an hour at that level. Then give us a call. Call us at the main number for Grand Rapids Women's Health, 588-1200. Talk to the doctor on call or the nurses in triage if it's during the office hours. And if it's time for you to go to the hospital, we'll call the hospital for you and they'll know that you're going to come. So that's kind of how we like to do it, and that's what we're looking for with contractions.
Hi, I'm Erin Hoekstra, one of the OBs at Grand Rapids Women's Health. I am here to give you a hospital tour since we cannot have people coming into the hospital for the tour right now. So I am standing outside of the Women's Center entrance. This is where you want to come in when you are in labor, and hopefully you will have called our office already to tell us that you're coming in, talk to the doctor on call. I am at the corner of Ransom and Crescent Street, so we are back around the side of the hospital from the ER. And this is where we want you to come in. We have a separate entrance from the ER. We have a separate area where we evaluate patients for labor and delivery, and all of our obstetric patients over 20 weeks come in at this area. So next I'm going to take you into the OB triage area where patients are going to be evaluated. So this is the area where you're going to enter into maternity admitting OB triage. In this area of the hospital, we have RNs that staff this area, we have nurse midwives that are here, and we have nurse practitioners. So you will be evaluated by a nurse and possibly a nurse midwife or a nurse practitioner depending on what's going on with you. Come with me and I'll show you one of the rooms in here. All right, so here I am in OB triage. When you come in, you will check in at our desk here. Megan is our staff member that is staffing the desk right now, our secretary. And once you've checked in here, you will come into one of these rooms where you will be evaluated. This is what one of our triage beds looks like. We have monitors in these rooms. Your baby will be monitored and your contractions will be monitored. We evaluate patients here for labor, water breaking, problems with your baby or pain that you have during pregnancy, and many other issues that patients are evaluated for in this area. If it is determined that you are going to be admitted to the hospital, your doctor will be informed and be in touch with the nurses here, and then we will bring you upstairs to a labor room. So next I will show you that area of the hospital. So here we are in labor and delivery. I'm going to show you a standard labor room and what things look like in here. Follow me. So here we have our standard labor bed. It looks pretty similar to the bed that you would have had downstairs in triage too. What we like about these beds is when it comes time to deliver your baby, we can put up stirrups to put your legs up. We can take the end of the bed off so that the doctor can be there to deliver your baby. You will probably just be in the regular bed most of the time. If you come in and you want to walk around, we let you walk around in the hallways. We have birthing balls that are available. We have tubs in all of the rooms that you can use. And as long as your baby is doing fine and there's no contraindication, you should be able to do all of those things. Once you get to this room, you will have a labor and delivery nurse that is dedicated to you. You will have a monitor on for your baby. You will have a monitor on for contractions. If you are doing great and you want to move around a bit, you do not necessarily have to be monitored the whole time as long as everything is going well. You will be met here by your labor and delivery nurse, and then you will have an anesthesia nurse that comes and talks to you. They will talk to you about the epidural. Even if you think you don't want an epidural, just talk with that anesthesia nurse. If something urgent comes up or if you decide to get an epidural, they will be available to you. The other pain medications that are available is that you can get some IV Stadol, which is a narcotic. And that is a great thing to use before you would get the epidural. Once you are here, we monitor you to see the progress of labor. Some patients end up needing Pitocin to help things along. Some patients have to have their water broken. Sometimes we place internal monitors. If you have questions about those things, I would encourage you to talk to your doctor about those type of things. Your doctor may be in here some parts of your labor, but probably not the whole time. So your labor and delivery nurse is going to be your best friend here and take really great care of you. And all the staff here is here to try to make your labor experience the best that it possibly can be. I will show you the bathroom here just so you know what it looks like. It's a pretty standard hospital bathroom. So we have a pretty good sized tub that you can use in here, and as I said, as long as your labor is going fine and your doctor approves it, you should be able to use that for a good pain control technique. These are the same monitors that we have downstairs, so that's where we monitor your contractions and that's where we monitor your baby. If you have to have a C-section, we have operating rooms right here on this floor that you would be taken to. And we have staff available all the time that are available to do a C-section. If you have a vaginal birth, the vaginal birth will take place in this room. And then you usually stay on labor and delivery for at least 2 hours after a birth, vaginal or C-section. And then you're gonna move upstairs to a postpartum room. So I will bring you guys upstairs next to a postpartum room so that you can see what that looks like. So I'm here on 8 Center, which is one of our mother-baby units. We have 3 floors that patients come to for the most part postpartum, 6, 7, and 8 Center. So all of this is in that center tower where you would have come in initially. 4 Center is another unit that is for obstetric patients. That is mostly for patients that are here preterm or perhaps patients that had other complications that they've been in the hospital for a longer period of time. Now let me show you one of our postpartum rooms. You can follow me down the hall here. So this is one of our standard postpartum rooms up on 8 Center. You will have your own private room. You will have a nurse that takes care of you here. There are nursing assistants that work up here as well. They help with newborn care. They help with circumcisions. Most patients on this floor will stay for either 1 or 2 nights after a vaginal birth and 2 or 3 nights after a C-section. So this is a pretty normal room. The cafeteria brings you food here. It's actually pretty good cafeteria now. You can see over here there's a breast pump here, so they do provide hospital grade breast pumps, and they will provide the supplies if you need to use that while you're here. So you do not need to bring any of that with you. We have just a normal looking bathroom here. There's a nice shower here. They're gonna provide you with pads and ice packs and ice diapers and whatever you might need after your delivery. While you are here, your doctor will also come by and take care of you. We round on our patients every day that you are here. If you have a baby boy and you would like him to be circumcised, that is our team that does that for you, and that is usually done either the first day after delivery or definitely before you would go home. I hope that you liked this hospital tour and that you feel a little bit more confident about what's going to happen when you come to the hospital. We feel really confident that our hospital is a safe place for you to have your baby, and we are all here to take really good care of you. I hope that you guys all have a really good day.
So a little bit about hospital information. It's important to know that the hospital is doing all that we can to address your safety in the COVID-19 pandemic. So there are limited numbers of entrances. Like I said, the entrance at the Women's Center is one of the few entrances that staff can enter, but that's also where you will enter should you come in labor or to OB triage for any reason. And that is at the corner of Ransom and Crescent. So when you call us and think that you might be in labor and we tell you to go to the hospital, that's where you go. You can be dropped off there, security will meet you, and then your partner can park in ramp 6 and meet you inside. OB triage is on the A level right there next to that door, and in OB triage you are assessed by a nurse midwife who is in communication with your doctor about what's going on. Is your water broken? Are you having contractions? What's your cervical dilation? How does your baby look on the monitor? What's your blood pressure? And all those things are determined in OB triage. If you are in labor or your water's broken and we determine that you're going to be admitted to the hospital, then you'll go up to labor and delivery, which is on the 2nd or the 3rd floor of the hospital. This is where you'll progress with your labor and give birth to your baby. C-sections are also done on the 2nd floor of the hospital, and so you can progress right from labor to your C-section if that needs to happen, and we'll talk a little bit about that in the future. If you're scheduled to have a C-section, then you go in the same door and you go to triage and tell them you're there for a C-section. They'll take you right up to where you need to be. Some things to think about. So normal progression of labor and delivery. If you come in with contractions and go up to labor and delivery, typically for a first-time mom it takes about a centimeter an hour. There's a huge variation. Some people have 4-hour labors, some people have 24-hour labors, so there's a big wide variation, but that's about an average. So you get to dilate to 10 centimeters. Once you're dilated to 10 centimeters, then you start the pushing phase of labor where you get to push to have the baby come out through the vagina, and pushing can last anywhere from 30 minutes to 3 hours for a first-time mom. The average would be a little over an hour, somewhere between an hour and an hour and a half. It kind of depends on if you get an epidural or not, and we'll talk a little bit about pain medicine next. While you're in labor and delivery, you're in a private room. Right now during the COVID-19 pandemic, we're asking your partner to stay in the room with you at all times. They can order food service and have beverages delivered, but to stay in the room and not go into the hallway or the other parts of the hospital for your safety and for our safety. Your baby will be delivered in the room. You'll have a labor and delivery nurse assigned to you, and one of the doctors from Grand Rapids Women's Health will be delivering you. Historically, what we've done at Grand Rapids Women's Health is we've had the doctor that you see normally will try to be the doctor that will be there for your delivery. For example, if it's during the workday, we're the ones that leave to cover your delivery. Right now, we've changed that model a little bit. So what we're doing is we're having 4 providers in the office at any given time to see the patients that are coming in for that day. This allows us to be separate in different parts of the office so that we're not crowded and we can maintain our social distancing from each other. And that means that you may see different providers for your OB visits. It also means that we have one doctor in the hospital at each time. So there's a doctor there during each day shift and a doctor there during each night shift. And it might be a different doctor for the delivery than the one that you were seeing for your pregnancy. Be assured that all of the doctors are very interested in your safety. They're all wonderful people, and we are there to take the best care of you possible. I worked on Monday. I got the pleasure of doing 5 deliveries, and it was just a really beautiful experience. And so I want you to know that even if you don't have your own doctor, we all are good people and we really care about you. In labor and delivery, you have some options for pain management. So you can choose to use Stayed-Up, which is an IV medication. It's a narcotic. That medicine really just helps you to feel more relaxed, not care quite so much. You might even feel a little sleepy. I have seen people fall asleep in between their contractions, which might be 2 or 3 minutes apart. which is kind of funny, but it helps you to relax. You still feel them, but you don't care quite so much, and sometimes Stadol is just what's needed to help you through that transition. Some people also choose to use Stadol early on. Some people don't like it. Number one, it's a narcotic, so if you have a history of problems with opioids, it's not a good choice. Or if you don't like the thought of not feeling totally in control, then it's not a good thought, not such a good choice. We're choosing right now not to use our nitrous. Nitrous is laughing gas that you often have at the dentist's office, but it can aerosolize potentially the COVID-19 virus. And since we aren't positive of everybody that's asymptomatic and maybe a carrier, we're choosing not to use oxygen or nitrous at this time, and that's okay. Epidurals are also available. 85% of women that come to the hospital will end up choosing an epidural at some point in labor, and that's partially because they find that labor is uncomfortable, especially first babies. It can be a long time. Contractions are painful. Totally a decision that's up to you, but it's nice to know what your options are and to be prepared. An anesthesiologist performs your epidural. They come in the room to place it. Once the epidural is requested, we give you a bolus of IV fluid. That's to help boost up your blood pressure, because the epidural dilates your blood vessels. The medication they give does that, and that can drop your blood pressure, so we give you a boost of fluids, and then the anesthesiologist will place this little needle between the bones in your back while you're sitting on the edge of your bed under sterile technique, and they'll thread a little tiny catheter like an IV tubing through the bones in your back. At that point, they'll put medication in there, usually some pain medicine and some numbing medicine. That catheter stays taped to your back, attached to this IV and this pump the whole time you're in labor, so it usually keeps you pretty comfortable. You really are kind of numb from about breast level down. You stay in bed at this point. You still usually can move around and shift positions, but you are much more comfortable. Often you don't even feel your contractions. You can rest and sleep, and it does not increase the risk of C-section. Can make your labor a little bit longer, but many women will choose this as an option, and so it's good to know about it. Should you desire it, it's an option that's available for you. Induction of labor. Induction of labor is sometimes done for people who have a medical indication, for example, hypertension, patients with chronic high blood pressure or hypertension, high blood pressure that's exacerbated by pregnancy, usually need to deliver earlier, sometimes as early as 37 weeks of pregnancy, because sometimes it can age the placenta. So sometimes we'll induce them or cause them to go into labor. Sometimes people will be induced because they have diabetes, there's something going on with the growth of the baby, or there's maybe another medical reason. Occasionally we'll do an induction because you'll go past your due date. Sometimes close to 41 weeks, certainly by 42 weeks, when we know the risk of stillbirth increases, we will talk about doing an induction. Inductions can be done safely. I know that there's a ton of information on the internet. Again, be careful about what you Google. Inductions are really safe, and they don't have to be super traumatic. There's two different ways to do it. Ripening of the cervix can be done in a variety of ways, with either medication, like a little tablet of Cytotec that goes in the vagina to soften and ripen your cervix. Sometimes a balloon, like a Foley catheter with a little balloon, is placed through the cervix, and the balloon is dilated and taped to your legs, so it pulls down and mechanically starts to dilate your cervix. And often Pitocin, which is a synthetic of what your brain makes in your pituitary gland to cause contractions to happen. It's very safely given through an IV pump, and your nurse slowly starts it at a low dose every 30 minutes, increases that dose by 1 or 2 until you're starting to have contractions that are regular every 2 to 3 minutes and painful. So yes, Pitocin causes painful contractions, but that's kind of the point of labor. And then until you're starting to progress and having cervical change. Occasionally Pitocin is added to labor that just slows down. So some people come in labor and then they slow down and their cervix isn't changing as quickly, and then you need a little added Pitocin. Excuse me. So those are things that may occur. Sometimes we offer to break your water in the process of labor just to speed things up. Sometimes breaking your water is a really great way just to get things moving or to expedite the process. Of course, always this is done in conversation with you about why we might want to do it, what your preferences are. A C-section is done about 20% of the time. I would say that at Spectrum Health, we have about a 22% C-section rate. In our practice, it's just a hair lower than that, but there is a chance that you would require a cesarean section. Sometimes it's because there's a reason, like you had a car accident a long time ago and you fractured your pelvis, and there's a reason why the orthopedic doctor recommended that you never had a birth through there. Sometimes it's because in labor, the baby's showing signs of stress and not tolerating labor, and we recommend for the safety of your baby that we think it would be better to expedite delivery, and a C-section would be the best way because your cervix is not dilated all the way. Sometimes your cervix dilates but then stops dilating no matter what we try to do. And believe me, we try a lot of different things to get you to be able to deliver vaginally. So there's a variety of reasons why a C-section might be performed. Again, they're performed right there in the hospital on labor and delivery, on the labor and delivery floor, and done with an anesthesiologist in the room with you. If you have an epidural already, the epidural is used for the anesthesia. So they dose it, you're awake, your significant other can be in the room with you, and you're a doctor from Grand Rapids Women's Health, and usually either one of our partners or one of the residents from the hospital will be the ones that will do your surgery. And there's a nurse in the room for you, a scrub tech in the nurse for you, and a nurse in the room for the baby. Sometimes a C-section is needed in a more urgent fashion, like a true emergency. This is really, really rare, where you would require a general anesthetic because you don't have an epidural, we don't have time to place a spinal block, which is the other preferred method, and you need a general anesthetic. The last time I did this was about 7 years ago, so it's not very common. I know when you do your reading, sometimes it sounds really scary. If that does occur, then your significant other cannot come in the room with you because we're focused on taking care of you and your baby and responding as quickly as we can. But just so you know, that's something that can happen, and we can do that really darn quickly if we need to, but it doesn't have to happen very often. The length of stay. We are trying to expedite discharges from the hospital as quickly as we can right now because of the COVID-19 pandemic. Reducing the amount of time that you're in the hospital, your exposure to any extra people that you need to see. But we also want to make sure that you're safe. So our goal right now for a vaginal delivery is to have you go home after 24 hours of birth. You'll see the obstetrician and the pediatrician the day after, and if you need to see the lactation consultant, they are also still seeing patients. After cesarean section, we're trying to have you go home after 48 hours. This is assuming that you are safe and ready to go home. If there's something, a complication or a problem, then of course we're going to keep you and take care of you and give you whatever care that you need. Those are the basics about the hospital. Trying to think of other things. Operative vaginal delivery. So there might be an occasion once you're completely dilated where there would be a reason why you would need help delivering through the vagina. That's called an operative vaginal delivery, and that might include a vacuum or a forceps delivery. I feel like the doctors at Grand Rapids Women's Health have really excellent training in these things. I sometimes do recommend a vacuum or a forceps, of course with conversation with you about the reason why and the pros and cons of why we would do that versus a cesarean section. But sometimes it's a really nice option to avoid a C-section in a scenario where, for example, the baby's heartbeat suddenly changes and we feel like, okay, if you push another hour, the baby's going to come out, but the baby needs to come out more quickly than that. Or you're just exhausted. Let's say you've had a long labor, you've been up for nights in a row, and you've been pushing for a long time and you feel like you have no more to give. Occasionally that's a scenario, and then maybe there's a way that we can help you. Again, a conversation that you can have with your healthcare provider, the doctor that's on at the time, will be able to discuss this with you and go over the pros and cons, and you'll get to make a choice about that. But sometimes it's a really nice option for a really safe delivery and allows you to avoid having a cesarean section if that's something that you decide that you want. Internal monitors are something that we use. So usually you get the belts with the monitors that record the contractions and the baby's heartbeat. Sometimes we use intermittent monitoring if you're a really low risk pregnancy and you don't have an epidural and you're still moving around in your room and maybe sitting on the birthing ball or using the shower or the tub. While you're in labor, we can intermittently monitor just with a Doppler like we use in the office. Sometimes we can do continuous monitoring, and they have both the ones that are attached with a cord and the telemetry, which is wireless, which is super cool. You can sit in the tub with that for a long time. And sometimes we use internal monitors. So internal monitors, the one that records contractions is called an IUPC, intrauterine pressure catheter. It's a little tube with a transducer on the end that slides through the cervix and sits next to the baby inside the uterus. It actually records the millimeters of mercury that's created by your uterus so that we know exactly how strong your contractions are. It's really good to know. Let's say you're not making good cervical change, you've been for a few hours and you're not dilating, then that allows us to know, are your contractions strong enough? And it tells us a little more information than just the one that we place on the outside of your belly. The baby's heart monitor, called a fetal scalp electrode, is a tiny little wire that's attached to the top of the baby's head, and it shows us the exact electrical activity from the baby's heart, not just the outside ultrasound version. And sometimes that's the safest way for us to determine that your baby's safe in labor. We might recommend that as well. Again, conversation that we might have in labor, but just so you know some of the things that may occur while you're there. Birth plans. Birth plans are not required for labor, but they're certainly welcome. So I've been in practice long enough to know that birth plans are really the advent of the internet. Nobody really had birth plans when I was delivering my babies 24 and 21 years ago, but a lot of people now have birth plans, and there's a lot of birth plan resources available on the website. Spectrum Health even has a templated birth plan on their website. If you want to create a birth plan and list some of your birth preferences, just keep in mind a few things. It's a great opportunity to dialogue with your doctor about some of the things that you're thinking about labor, and it shares some information with your healthcare team at the hospital. But it's not a script for your labor, and some people get really disappointed that they've spent all this time kind of writing exactly how they want their labor to go when we really have no control over it. Nature controls birth, and we know all of the things that we can do to respond to how that occurs, but we really can't control exactly how it's going to go. And so I just want you to have the best, most positive experience that you can possibly have and feel really good about it at the end. And I don't want you to feel disappointed if it doesn't happen exactly the way that you picture it right now, and it most certainly won't. But I want you to feel positive about it and good about everything. My number one goal is healthy mom, healthy baby. And my number two goal is to make it exactly the way you want it. And so just keep that in mind when you're looking at your birth plan or thinking about whether you want one. And then bring it to the office with you if you do decide to have one, so that we can go over all the different points that you have on your list, so that we can review them and maybe add some points for you. So I think that's what I have to share about hospital information. If you have any additional questions, please bring it up at your next OB visit. Okay, so now you've had your baby. So once you've had your baby, let's talk a little bit about what happens. If you've had a vaginal delivery, we are going to put the baby right on your belly, and we're going to try to have delayed cord clamping. The reason that we try to delay the cord clamping is to let the blood flow from the placenta through the umbilical cord to the baby. We found that it increases babies' hematocrits, which is the amount of red blood cells that they have, and they do a little bit better. Some people have a preference to let it go for longer, like 3 minutes, or to wait till it stops pulsing. If the baby's doing well, then that's fine. Most people are fine letting it go longer. Just let your team know that that's your desire. 1 minute was the determination of experts at Spectrum Health based on the literature of the benefit to the baby, and so that's why we choose to do that. So after that time, we'll clamp and cut the cord. Your significant other is able to do the cutting if they so desire, and the baby then will be placed on your chest for skin-to-skin contact. We know that skin-to-skin increases bonding with mom, helps transitioning, improves breastfeeding success, keeps temperature regulation, and so there's a lot of benefits to skin-to-skin bonding. And we'll do that for the very first hour of life until After that is when we do testing like footprints, weights, and do the initial tests like the vitamin K shot, the hepatitis B vaccine, and the eye ointment for the baby that is regularly recommended. So after that time, on a C-section, we can do the same thing. 1 minute delayed cord clamping, and then we hand the baby over to the baby warmer. If you want to do skin to skin, either mom or your partner, that is fine too. Under most circumstances, we're able to do that. So please just let us know. After about an hour and a half to 2 hours in your room or in the recovery room, then we're gonna allow you to go to your postpartum room. In the postpartum room, you're gonna have a postpartum nurse that's gonna take care of you. And we're gonna do assessments where we're gonna check your belly about every 15 to 30 minutes to make sure that your uterus is nice and firm. This involves a little bit of uncomfortable rubbing. Your uterus goes from this big to about this big, and we can feel this little firm ball right by your belly button. And we wanna make sure that the uterus clamps down so that your vaginal bleeding decreases and you don't have too heavy a bleeding. Looking out for risk of hemorrhage or bleeding after you deliver. We have no additional visitors at this time. If you have a tear or a laceration down by the opening of the vagina or in the vagina, there are several things we do to help you take care of that. An ice pack is your best friend, and we start giving you ibuprofen and Tylenol right away. I know you haven't been able to have ibuprofen for the whole time you've been pregnant, but it suddenly becomes your best friend. So we give that to you right away, whether it's a C-section or a vaginal delivery, and a nice ice pack for your perineum or for your incision, and that is really a great combination. If you have stitches down below on the perineum, we can give you some numbing spray called Dermaplast that can help. We can also give you some Epifoam if you have a big hemorrhoid, and that's like a spray, foam spray with some steroid in it. So there's a lot of things that we can do. The other thing is you get a spray bottle. It's like a water bottle with a spout on it where you can spray it on there after you use the bathroom and then blot dry so you don't have to use uncomfortable wiping. The other thing is for babies, will help you if you choose to breastfeed with that early, getting the baby to latch on within the first hour, and then we have a whole section talking about breastfeeding afterwards. If you do not prefer to breastfeed, that's okay. Just let your team know, and we have formula available for you in the hospital. You don't need to bring it. You also don't need to bring your breast pump. We have those things available, and so I think that it's better, especially with COVID-19, that you leave your breast pump and supplies at home and use the hospital ones. We have everything available for you, and we're going to do everything to get the baby started, to latch on and give you the support that you need. So that is postpartum. In your room, there's a lot of education that's going to happen. Your pediatrician will come the next day, your obstetrician will come the next day, the lactation consultant can come. We'll talk to you about all the things that you need to know before you go home. You can answer all your questions. There are videos that you can watch on the hospital monitor about car seat safety, infant CPR, and there's lots of resources for you. We're not going to leave you going home feeling scared. So that is all ready for you. Let's see, baby friendly. Just a touch base on baby friendly. I know that Kelly is going to talk in her segment on breastfeeding a little bit. The hospital is baby friendly, and that is a World Health Organization and UNICEF designation given to hospitals who have met a series of criteria to get this designation. What that means is for women who state that they want to breastfeed, we have met the criteria to say that we are being the most supportive that we can be. I don't think baby friendly is 100% perfect, but what it means is that we are going to try to limit pacifier use, keep the baby in the room with you as much as possible, minimize the use of formula and nipples early on, and try to give you the education that you need to have success with breastfeeding. So that's the basic about baby friendly hospital initiative. Skin to skin is an important part of that. There's a lot of other steps involved, but that if you hear that term and you see that advertising, that's what baby friendly means. And Kelly is going to talk to you a little bit more about breastfeeding.
Hi, I'm Kelly Emery, and I am a lactation consultant and nurse and owner of Baby Beloved. I've been working with moms for about 25 years now, and I just wanted to talk to you a little bit about breastfeeding in the early days. Breastfeeding, as if you haven't figured that out yet already, can be a very loaded and confusing topic. Lots of information out there on the internet, and not to mention like from your maybe horror stories from your sister-in-law, or maybe some good stories floating out there too. But it can be a big mix of like what's normal, what's not normal, why does breastfeeding work sometimes, and why does it not work other times. So the first thing I want to talk about is taking a breastfeeding class. This will just be a short little snippet, but there are longer, like I teach a 3-hour breastfeeding class that goes way in depth about most of these topics. So I highly recommend taking a breastfeeding class. It is if it's something that you've never done before, it behooves you to get some information about what's normal, what's not normal, how your breasts work, how your babies work. You know, when we went through middle school health ed class, we just skipped right over our breasts. We talked about our periods and whatnot, but we really didn't talk much about our breasts. But they're amazing things, and there's lots going on around your breasts right now while you're pregnant, and even more so, more to come once your baby comes. So it's a good idea to get educated about your body and about babies and breastfeeding and what that's all about. And I highly recommend bringing your support person. Any kind of partner you have, a dad. If your support person is going to be your mom, bring your mom. Just like bringing a second set of ears to listen to all this is highly recommended. When we look at the data, and we do data, lactation people do data and research on this sort of thing, and we look at what makes breastfeeding work for some people and not work for others. Time and time again, we find that it's not the influence of the lactation consultant, it's not the pediatrician or the OB. The number one factor whether breastfeeding works or not is the dad and the partner, and whether they're on board with it, because he's going to be with you at 2 a.m., not me. So he's going to be someone who knows what to say to get you through, how to advocate for you, how to help you out in the ways that you need helping out. So if the dad or any kind of support person can come along, that is, again, highly recommended. Breastfeeding, going through the classes is the first part of it, but really it's going to be on-the-job training. So it's when you actually have the baby in your arms is when the rubber hits the road, and you're going to understand more about what breastfeeding is about. And that's completely normal, but it's a stepwise process. So just like riding a bike, if you took a class, if you'd never seen anybody ride a bike before, but you took a class and you read a huge book on how to ride a bike, that's not going to be as helpful as you watching someone ride a bike. You watch your older sister or brother ride the bike, and you kind of get a feel for where they put their hands and their feet and what they do and how fast they go. And then when it's your turn to get on the bike, you have a better understanding of what it's supposed to look like. You'll fall off a few times, and you'll get back on the bike, and then you'll fall off a few times. You may have some training wheels behind you, and maybe your dad holding the back until you feel comfortable to just go out on your own. But it is a process. It's a learning process. So the same goes with breastfeeding. So the breastfeeding class is the first part of kind of learning. And then also, if you know anybody for whom breastfeeding is working and working well, if you can get with them and kind of just watch them breastfeed. And just the more you watch it and you see it and ask your questions, the better it's going to implant in your brain as well. And you have the benefit of YouTube nowadays, where you can, without asking anybody, you can just go on there, and there's tons of breastfeeding videos. So that's something that's in your favor as well. So you can kind of see what it's supposed to look like and just the different ways that women do it. So that's something that's free to do, and I highly recommend doing that as well. All right, so let's talk about the first couple days when you have your baby. Actually, back up a little bit even before that. You are making milk. If you've made it past the 16th week of pregnancy, you already have the first meal made. So it's called colostrum, and it's in there, and it's thick, and it's yellow, and it's very small amounts. But it's just waiting in there, kind of swirling, waiting for your baby to be born. So you don't have to think about it. You don't have to look on any recipe book, anything like that. Just, it's already made for you. And it's just because we're mammals, that's what we do. We make milk. So you don't, even if you're gonna formula feed, you're making your first meal is already made anyway. So just that's how that happens. Colostrum in small amounts, like I said, and even in the last parts of your pregnancy, you may even leak a little bit, and you'll notice on your bra that, oh my gosh, there's some yellow seepage on my bra, or my bra is wet. That's completely normal. It just means your body's making a lot of milk, and it's just kind of that colostrum, and it's just kind of seeping out. So that's not a big deal. You can wear some nursing pads if you want to. But it's yellow because it's really high in beta carotene, which is the same sort. It's a very strong antioxidant. It's what you find in like carrots and that sort of thing that gives it that yellowish orange color. A couple days later, maybe a week or so later, it's going to turn into like a more whitish color that you might think of when you think of milk. But the normal first milk that comes out is going to be yellow, so that's completely normal. And some women leak and some don't, so don't read too much into that. If you're not leaking, it doesn't mean you're not making milk. It just means you get to save a lot of money on nursing pads, so that's okay. So when your baby comes out and your baby's first born, we're gonna try our best to do this. It's called like the golden hour, or that first hour where we put the baby skin to skin with you. As long as mom's healthy and baby's healthy. And the nurses and doctors will do all of their assessments. They'll do a quick check to make sure everybody's healthy, and then they're just going to let the baby stay on you until that first feeding occurs. So you're going to hold the baby. They're going to dry it off a little bit. They're going to put a blanket over both of you to keep your baby warm next to you, and you're just going to lay there and you're going to stare at your beautiful baby, and you're just going to kind of take in everything that just happened and celebrate the new moment. But sometime in that first hour, when you're laying back and you're holding the baby on you like that, your baby's going to start something called a breast crawl, and it is the most amazing thing to see. Like it's my favorite part of my job, if I get to witness it at all. So it's something where the baby is on you, and after they're kind of gobsmacked, like, oh my gosh, what just happened? And then after a while, it could be 40 minutes, could be 30 minutes, could be 45 minutes, whatever. All babies will start doing this, displaying these different reflexes that help them crawl to the breast. They're born with over 20 reflexes that help them crawl to the breast. You don't have to really help them too much get to the breast. They're already capable little beings even from the get-go. And if you think of any other mammal on the planet, a dog, a cat, a little piglet, the mother dog, cat, and piglet don't latch their little newborns. Those little newborns have to crawl and wiggle and find their way, even if they're they can't see. They go by sight, and they go by smell, and they go by their instincts to find the teat and latch on. And we're finding when we give our little smart babies the opportunity to do that, they can do that too, and it's the coolest thing to watch. Now, if for whatever reason you have to have medical interventions or something is going wrong, that they have to take care of you or the baby afterward, and then you guys get to do skin to skin, that's okay. These instincts are in place for a long time, so you can reproduce that even back in your postpartum room or when you get home. So it's not something that's like a one opportunity that you get to do this breast crawl. Your baby will be able to do it over and over again, even when you get home. So hopefully, though, our goal is to get that baby on you, skin to skin with you, and we don't do any of our major assessments. We don't take the baby away until after that first feeding is done. And the reason for that is when your baby comes out, its gut is sterile. Its mouth, its throat, its esophagus, everything is sterile. It's only been swallowing your amniotic fluid, and that's it. So when it comes out, we don't want to take it away and like populate it with all of our nurse and hospital germs before you've had a chance to have your baby on your skin and your baby gets your flora, your microbiome on your skin gets into your baby's gut, which is what we want, which is a good thing. Another reason is the colostrum. When the baby takes the colostrum, as remember I said it's very thick, and so it's a small amount, but it's very thick. So when the baby takes it in, it goes down the throat and the esophagus, and it's sticky, so it sticks to the inside of your baby's esophagus and throat. And what that does is it creates a barrier. So like say your Aunt Mildred comes in and starts coughing all over your baby. Your baby may take those viruses or bacteria or anything in, but because of that colostrum barrier, it's going to be a lot harder to get into your baby's bloodstream to cause any problems. So the colostrum it is a feeding-ish, it is a good feeding, but we look at it more like a medicine and a barrier more than anything else. And because of this, it's really, I highly recommend, again, even if you don't want to breastfeed, like breastfeeding is not for me at all, that I'm not even interested in doing that. Even if you can just nurse that one time right after delivery so the baby gets your colostrum, that would be a huge gift to give to your baby. And who knows, maybe you'll like it, maybe you won't, but at least your baby would, you'd have tried it, and getting baby that colostrum would be a super wonderful thing to give to your baby. So the baby will first, back to the breast crawl, and I go to the website, go to the YouTube actually, and type in breast crawl or biological nursing. There's lots of things for it, but breast crawl is probably the biggest hit that you'll get to watch a baby actually crawl to the breast. So it's very fun to see. So what the babies all do, they all do it in the same row, same order, so that we know that it's kind of hardwired into human babies, because your baby didn't take a breastfeeding class, so they didn't really learn how to do this. So we assume that they must be hardwired to do it. So they use their little stepping reflex to kind of scoot up and squirm around and find you and find your nipple. And they use their little hands to plant on your body. And then they start kind of sticking their tongue out and kind of sucking on their fist. And then they start kind of bobbing their heads and kind of flipping their body and twisting their body to travel. They choose the left or the right breast, and then they go for it. And sometimes it's just a wiggle, and sometimes they just throw their body over there. So your job is just to lean back and have the baby lean back on you, as belly to belly with you on its belly, with its head's kind of tilted back, and it uses its arms to get to you. And you just put your arm up and help however you feel naturally to do so. But try not to overthink it. Just go with your gut instinct about it and follow your baby's lead. And the nurses are there to help you as well, to help get in a comfortable position. They might put a pillow underneath your elbow, who knows, whatever you need at that moment. And then the baby just goes over there, and they open their mouth, and then they latch on. So it's very little that you have to do, and it is a really cool thing to try if you're willing. So after the first feed, so after we know that the baby's got the colostrum and they've gotten the first feed and they're so happy and all that's done, then the assessment begins, and make sure the baby's okay, and you guys fall in love even deeper with your baby, if that's possible. And then, and then from there, while you're in the hospital, you're just gonna do lots of skin to skin like that. And if the baby starts kind of bopping over, you just follow their gut or follow their lead again, and just kind of keep doing that. Now, if you're getting sore, if you're having troubles, definitely ask for the nurses or the lactation consultants in the hospital to help you with different positions or ways that you can tweak it to get comfortable. But that's a lovely one. Just the laid back nursing, it's called too, is a lovely one to start with too, because your bottom may not feel so good right after delivery. So leaning back, doing a little bit more sacral sitting, is a nice way to go right after delivery, and in the forever, actually. It's one of my favorite positions. So in the first days, your baby's belly is very tiny. So here's a slide that shows you in the first couple days how little, and then how big your baby's stomach gets. And you'll see it's very small because you have a very small amount of colostrum. A couple teaspoons here or there is it big enough feeding in the beginning. And every day the baby's stomach will stretch a little bit more, and then they will need more. And that's around day 3, 4, 5 is when your milk supply increases. So that colostrum, more water is added to it, and you just start getting more volume. And just as Mother Nature would have it, as the baby needs more, your body will start making more. So how you ensure a good milk supply and for this milk to come in nice and fast for the baby is lots of nursing in the first couple days. So anytime the baby is sucking on their fists and kind of looking at you and sticking their tongue out, doing any kind of cue that they want to eat, it's go for it. It's like open buffet for the baby right now, open bar, anything, anytime. So you're just going to do lots of little practice times. They can be small feedings, they can be longer feedings, whatever it is, it's okay. Every single time it's going to signal your body to bring in the milk, bring in more milk, bring in more milk. And the baby gets a little bit of calories all throughout the day. So that's all good. Now the only time that this would not work is if your baby's premature or sometimes if you have diabetes, they may be checking the blood glucose level, or if there's some kind of medical issue going on, the nurses and doctors will guide you whether the baby needs more. But if everything's fine and everyone's healthy, the baby just lives off the colostrum until your other milk comes in, your more transitional milk comes in. So just, again, open buffet. You just nurse whenever your baby asks for it. I would recommend if the baby's going longer than 3 hours though, between feedings, I would unwrap them and just kind of talk to them, give them a little massage and put them skin to skin with you and at least try the breast. Sometimes it works, sometimes it doesn't. But if the baby starts going too long between feedings, just get your nurse to help. We have very cold hands and it usually wakes them up pretty effectively. They don't like us. So yeah, so do that in the first couple days. And excuse me. And what they're going to do, because there is no gauge on the breast, so it is a bit of a leap of faith. So you're going to be checking the wet and dirty diapers to see how much the baby's getting. So they will give you a chart, and you're going to be reassured by, oh my gosh, all these diapers, whatever goes in has to come out. So that's something that's very reassuring for you when you see all the diapers. And also, conversely, if there's not enough diapers, that's when you would call the doctor or ask your nurse or get some extra help to see if what's going on. So the nurses will all instruct you on that. So nothing you have to think about right now. They will guide you through each day of that. I would recommend, if you haven't already, to get your pump at a time if you can. The pump is something that all insurances, unless you're a grandfather plan, it should be covered by your insurance. Some insurances let you get the pump ahead of time, and some make you wait for when the baby's born. There will be a link to my website. There's a great Aeroflow is the biggest supplier of breast pumps, and so you can click on that, put in your information, and they'll send you an email about what your benefits are, what pumps you're eligible for, and all these different things, and they just like boom, they mail it right to your front door. So it's very slick. But every insurance is different, so you'll put in your insurance and they'll guide you on what you can and can't get, and when you can get it and when you can't. But if you can get it ahead of time, it's kind of cool to bring it to the hospital with you, or at least keep it in your car so in case you go into labor and you forget about it. Because if they have time, the nurses and lactation consultants, especially lactation, they can fit you for the pump and show you how to use it. There's the things that the breast shields, they're called, that actually go on your breast. They come in lots of different sizes. So having a lactation consultant actually watch you pump and fit you for the right size is very valuable. So if you can bring your pump to the hospital, please do that. And lastly, just know that breastfeeding requires a lot of room for awkwardness and vulnerability and grace. Especially grace afforded to yourself. It's easy to afford it to the little baby because they're so innocent, but giving yourself a lot of grace is something that is really needed, especially in the first couple of weeks of breastfeeding. Especially if you're someone who is kind of hard on yourself when things don't work out in life. So sometimes in the beginning, breastfeeding doesn't automatically work out in the beginning. Doesn't mean that it won't later. But if there's a few stumbling blocks in the beginning and you need some training wheels in the beginning, just know that that's completely normal. Most women do need a little help in the beginning. It's a social sport, it's a team sport. So it doesn't mean that you're a bad mom if breastfeeding is not working out. It just means that you need your community, and you need your support system around you, and that's when to pick up the phone, or have the dad or partner pick up the phone and get some help. It can be a support group. It's like the Fight Club in Grand Rapids every day of the week, except for during this quarantine, of course, but usually every day of the week there's a support group going on between all the hospitals, and those are free, and they're just a godsend to be able to see other moms and get some questions answered. If you want a more private setting, there's lactation in the hospitals, and then also outside. People that do home visits, such as me, will come right to your home if you want a more private setting. I'm set up for telemedicine. It's not the same as actually being person to person, but it's better than nothing during this quarantine time. So there's telemedicine options out there. Your pediatrician, your doctor, anybody, just reach out for help is the main thing, so they can get you hooked up to people. I'm not saying that breastfeeding isn't supposed to hurt a little bit. There's usually a little discomfort that comes with it in the beginning. But if you're cracked and bleeding and in tons of pain, like you're ready to throw in the towel, it's definitely time to pick up the phone or get on the internet or whatever and get some real hands-on qualified help. Someone who does this for a living, someone who really knows what you're going through and has solutions to help you heal and to get over this hump so you can get to reach your breastfeeding goal. And just know that it can take a couple weeks to feel confident and competent in this. And again, that's super normal. So know the normals and give yourself a lot of grace. Time to be vulnerable, time to fall down, skin your knees a little bit, and then get right back up on that bike. And please do not hesitate to call me or email me if you need help. The links will be below to my website, and my phone number is on there, and I am available just about all the time. So good luck to you, and have a wonderful birth, and I hope to meet your beautiful baby someday.
Hi, my name is Craig DeWitt. I am a licensed psychologist at Psychology Associates of Grand Rapids. We have an office on Cascade Road, but we also, for the last 12 years since the Women's Health Center opened, have an office on the 3rd floor and have had a nice working relationship with the doctors and nurses on the 4th floor. One of the areas of specialization for us is dealing with postpartum mood disorders, and that's why I'm here tonight. Just want to talk a little bit about that, what that is, how to treat it, how to deal with it, and going forward. And so one of the things we know about going through pregnancy, there are changes. Of course, there's change to your body. And so you're going through this, you notice this change, it's going to have, especially the 3rd trimester, may have difficulty sleeping more difficult. You may feel better in general, have more energy, but there are some of those bodily changes that make it worse to sleep and things like that, and maybe just move around. We also know there's some hormonal changes, both now, but particularly after when the baby is born. And so with those hormonal changes, there can be some shift in terms of how you deal with varying emotions like depression, anxiety, stress, those kind of things. Another change can take place in terms of relationship. And so you have a significant other or spouse, something does change in that both of you are not getting sleep. There is some stress on both your parts. Maybe your response or reaction to one another changes. And so there can be some of that tension that does exist at times. There can be a change in finances. We all know babies cost money. My kids, when they started having babies, all the contraptions and all the stuff that they got to purchase and fill up the back of their car with all this stuff, it costs money, and plus all the diapers or whatever you're going to use. There's also change in career, and I realize that some of you will be going back to work, and it's a difficult thing to know, but I'm not sure how I'm going to deal with that change. And so as a result, there can be added stress about that. Also, how do I function with less sleep and going back to work? Those kind of things. But also, for some who may stop working or go part-time, there's a shift there too, thinking, maybe I'm missing my job. Maybe I'm missing some of the people I worked with. That could make more stress for you. And then finally, just lifestyle. I mean, we all know that once you have a baby, things do change. It's wonderful, but there's also times where, you don't have the spontaneity. You just can't go out and do things with friends. You're maybe closer to home sometimes. And because of that, I guess people deal with that in different ways, but we know that's a stressful thing. And so So those changes are stressful. They can lead to more depression and anxiety, and we want you to be aware of that. Now, we all know about the baby blues, or at least we've heard about it, in that about 50% of women will experience the baby blues. And for the first couple weeks after the baby's born, you may feel a little bit down, tired, because you're not sleeping most likely, but just kind of down and not feeling yourself. And that does go away. But for the women that does not go away, for 15 to 20% of women will experience a postpartum mood disorder. And that's something that goes on for an extended period of time, into a month or 2 months, and even beyond that, up to a year. And so we want you to be aware of that and recognize the symptoms that come up. Now, we kind of know, and we've heard about depressions of depressive symptoms or anxiety symptoms, and so that feeling down, feeling worthless, no motivation, just really lethargic, angry, upset easily, those kind of things, worrying about stuff that you normally wouldn't worry about or be concerned about. And so we're trying to change, let you look at those things and say, if they're not going away and there's no way of resolving those feelings, that you're most likely going through a postpartum mood disorder. And so we want you to be aware of that and realize that you're not doing anything wrong. It's nothing you've not told yourself to just buck up and just deal with it, or that I can just put on a happy face. That this is something that you cannot control. And so we want you to be aware of that, so that you can, first of all, be gentle with yourself, be aware that I need help, and that there are people and resources out there to help. Now, the first order of help is the significant other and husbands. You guys, part of it is that we want you to be aware of these symptoms, have some sensitivity to the fact that the mom cannot do anything or change how this feels. And so, guys, read some articles, read some books. Websites are out there. Postpartum Dads is one of them that I use a lot of times, refer to. It's a great resource. It kind of tells you, okay, these are the ways in which the mom may start to feel and how they may start to act, and what can be your response to them. I love it when they have on there, things to do and not to do for the mom, things to say and not to say. And so I encourage you to, really pay attention to that. And for yourself, get some support from some guys too, who may have had a wife who has gone through this. Talk about some things that you could do to be of help. Do things for your wife. Give her time to rest. Give her a break from things. Whatever she asked for, you try to respond to that the best way you can. It's also, I think, important to receive help from friends, family, those kind of things. So if you need help, ask them, and be very specific, and almost be almost selfish for yourself, because this is for you and your baby. I remember my wife, when we first had our first child, one of the things that we did, we lived in Baltimore at the time, and so my parents drove up. They were going to help us after the baby. Helping us meant my mom would sit on the couch holding the baby. My wife would maybe get a shower, take a nap, but a lot of times doing housework around the apartment. And so that did not help. And we learned after that how to set some limits and boundaries on who, first of all, who comes over and visits, but more importantly, what do we need for them? And so be guarded for yourself. Take time and think through this. What do I need for me? One of the things we want to be aware of too, there are some factors that may make you more prone to postpartum mood disorder. One is a family member who has gone through that, because we know there's a genetic component sometimes. Maybe you've had a very severe PMS in the past. Maybe there's been a previous trauma in your life. Maybe there's a conflict or so between yourself with a spouse or with family members. Those kind of things. So there's events there that can create more stress. And so just be aware that that may make you a little more prone to that. So what do we do about this? And first of all and foremost is be honest with yourself and especially be honest with others. In the packet you'll see, and you've probably done this already, but the Edinburgh is a test that you take. And if you begin to show more symptoms and signs of depression and anxiety, it comes up in the test. And the doctors and nurses are monitoring that. But I encourage people to take it after the baby's born and to look at those kind of things and see how you can address those issues. So besides being open and honest with yourself and others and let them in, do some self-care for yourself. Know what you need, ask for it, sometimes demand it if you really know what that is. The doctors and nurses, if they see this, they will likely make recommendation of possibly medication. If you've been on medication in the past for depression and anxiety, maybe that's something that may be helpful in this situation. And in fact, maybe you're taking them already and just in preparation for this. But then also counseling, and that's where we come into play, and other therapists, if you have a therapist, really utilize them for some problem-solving skills, things that they can help you with, and also how to communicate more effectively. The other thing, and talked about support, there's a great organization in town called Moms Bloom, and it's in your folder, I think. But Moms Bloom is a group of women that come alongside women who are struggling. It's all free. You contact them, they will set you up with someone who will kind of walk alongside you and be there for you. And it's a wonderful resource, and I really want to encourage people to take advantage of that to the degree they can. And then finally, in real severe cases, it's dealing with the, if it's real severe, using something like the Pine Rest mother-baby program. I've had so many women that I've talked to and whose wives have gone through the program and can't say enough about it. It is just a wonderful program, and they receive so much out of it, including support, encouragement, relationships, everything like that. And so I really encourage people to take advantage if they can. So that being said, I hope you take away from this, first of all, don't feel shame, don't feel guilt, don't feel bad like you're doing something wrong if this happens to you. It happens to a lot of women. And seek out support. They have a support group here at the doctor's office. If you're feeling this way, take advantage of it. It's a wonderful place to be. You talk about self-care, you find people that can really understand you, and you can talk freely. So take advantage of that. Be open with the people around you. Don't suffer in silence. Don't put on a happy face when you're feeling differently. That only makes it worse sometimes. So I really want to encourage that transparency and openness as much as possible. So I'll leave you with that. I hope the rest of your pregnancy goes well, that as a family you can really enjoy the time together. But I know that some may struggle, and please take advantage of whatever resources you have. Thanks a lot.
Hi, I'm Dr. Drew Stransky with Rockford Pediatrics, and I've been asked to talk to you all about what to expect during your hospital course and also some tips for when you go home. Our goal is to help you raise and produce successful and productive children. Okay, wait a second. All we're going to do is try to get you through the first couple weeks here. All right, so first off, how are we going to choose a pediatric provider and office? There's different things that are important to different people, and I'm just going to brainstorm with you some things to think about. First off, let's tell you this. You're going to see this person a lot. In the first year of life, you see your pediatrician given 7 times for wellness exams. If you talk about the 2-week, 2-month, 4-month, 6-month, 9-month, 12-month, plus the initial checkup right after discharge from the hospital, that's 7 visits. And that doesn't include any weight checks or potentially sick checks somewhere in that first year of life. So it's something that you want to make sure that you feel comfortable with the office that you're going to be seeing. So things that are important to some people, location. Some people are requesting that their office be within a couple miles from their house. Some people don't mind driving a greater distance. It really depends on your needs. What are their hours? What are their availability? Are you able to talk to the provider? Are you able to talk to their staff? How do they handle after hours calls? And some groups will take their own calls, such as our office. Some groups will have a nurse triage line, and some groups charge you for those phone calls after hours. Those are all good questions to ask. Do they have any walk-in hours? What is their availability on weekends and after hours? What are their reviews like? I always recommend that families check out their Facebook or Google reviews, because you can hear a lot of information about what other patients have said about that office and their experiences. And then finally, some offices will do what's called get acquainted appointments. We do this probably a couple times a week, where we'll send new expecting families into the office. We sit down and talk to them, answer their questions, and allow them to tour the office and meet the staff and make sure that's a good, comfortable fit. And that might be a choice that you want prior to making that decision. All right, so now let's shift gears to what to expect in the hospital. So you've had your baby, and your baby's going to be seen by a pediatric hospitalist. And a hospitalist is a pediatrician that's trained just like I am, but they only do outpatient work. So their job is strictly in the hospital. So you'll see them for a couple days, and then when you go home, that's when you transition your care over to your regular pediatrician. That's pretty standard for most of the Grand Rapids area. So in the hospital, the pediatric hospitalist will do a good exam on the baby, will help to answer any questions that you have with breastfeeding, may even perform a circumcision if you're having a boy, and generally just make sure that your baby is doing well. Right after birth, a couple typical things that take place. We will use a substance called erythromycin that we put in the baby's eyes to prevent against bad type of bacteria that can cause scarring to the eyes, or in rare cases blindness. By using this antibacterial ointment, it virtually eliminates the risk of that. It's a one-time deal. Vitamin K is a vitamin that's made in the liver, and if you look at the baby as being immature in general, we want to make sure that they have enough vitamin K stores so that they can be able to clot and stop bleeding. So why was that important? Well, babies go through the vaginal canal and have the squeeze, which puts a lot of pressure on the brain, and if there was any kind of microscopic bleeding, you'd want to be able to stop that. And also for those who are having a boy with a circumcision, we would not want to do that if we couldn't stop the bleeding with the circumcision. So really important. Now, after about 6 weeks, that vitamin K stores kick in with the baby, and the need for supplement isn't necessary after that. So that's just a one-time situation as well. Hepatitis B is the only immunization that's given in the hospital. Hep B is a 3-part series, and we finish that in the office after you guys are discharged. Why do we give it in the hospital setting? It's because they test all moms early in your pregnancy to make sure that you're Hep B negative. But heaven forbid you contracted Hep B somewhere later in your pregnancy and didn't know it. By giving that shot, it almost eliminates the risk of the child getting hepatitis B. So instead of having to retest mom over and over again, we just blanketly give it at that stage and then finish the series as an outpatient. They'll do hearing screens in the hospital. It's a little machine that they'll take the baby to test to make sure that they're hearing properly. Some of the take-home points with that is it's very common for babies to fail that initially. It may be just one ear, it may be both ears. If that happens, don't worry. They'll repeat the test prior to discharge. I've had parents that come home where they still failed, and we send them to audiology and they end up passing. Every once in a while, we'll get a child that has some congenital hearing loss, and it's important to recognize early on because we can do something about that, whether it's hearing aids or extra therapy, so that it doesn't affect their speech as they're growing. We'll also do what's called a newborn screen. That's where they do a little heel pick on the bottom of the foot, and they blot it on a card, and that card is sent to the state, and it looks at a battery of tests that are important for the baby's development. Most of the time, this test comes back perfectly normal, but there are certain conditions that they look for. A lot of these you've never heard of before, but some that you may have would be cystic fibrosis, sickle cell anemia, hypothyroidism, and those are all things that we can correct or get to the proper attention to if the baby tests positive for it and can change their outcome and change their overall life. That usually comes back at about 2 weeks too, by the way. Blood sugar screens, they'll do that, especially if your baby is high risk. And the high risk category would be a child who's low for gestational weight, high for gestational age, weight, or if you're a parent who is a pregnancy diabetic. All of those children have a higher risk of having low blood sugars, and so they may do some checks and make sure that they're normal. If they're too low, it's very easy. We feed the baby. We can give them sugar water, we can give them formula or breast milk if it's available to get the blood sugar up, and then eventually that seems to equalize, and then it becomes a non-issue after that. Jaundice checks are another thing that will be done in the hospital. Jaundice, for those that don't know, are yellowness of the skin, and that is a normal physiologic process that takes place with babies as they are developing the first couple days of life. Partially it is because mom's breast milk has not come in, and the way we clear our jaundice is through urine and stool. So as the breast milk comes in and mom's feeding is going better, then the baby starts to clear that. Jaundice is only dangerous in high values, and we never let it get to that level. So in the hospital, do what's called a transcutaneous bilirubin check, which is a meter that they put on the baby's forehead, and it gives a reading. And if it's in a normal range, we don't go any further than that. If it's elevated, they'll do a heel stick like we talked about with the newborn screen, and they'll verify it through the lab that it's actually elevated. Well, what happens if a baby has too high of a jaundice reading? Well, there's things we can do. We can use phototherapy, which helps drive down the bilirubin to make sure that it's not in a dangerously high level. We can send babies home with what's called a billy blanket, which is a blanket of lights that helps to prevent the jaundice level getting too high as well. Sometimes they'll have babies get a bilirubin check as an outpatient. Those are all acceptable things. So jaundice peaks at about 2 to 4 days, and in the hospital, if you go home on day 2, they'll have a bilirubin check done, and that's why we see you 2 days after discharge typically, to check your baby's weight and also make sure that they have not, the baby has not developed excessive jaundice. So we kind of eyeball the kids in the office, and if it is elevated or they look excessively jaundiced, then we send them for another outpatient check. Circumcision. Parents will ask me, should I get it done? And the real answer is it's your decision. It's a personal, cultural decision. The benefits of the circumcision is it can decrease the risk of urinary tract infections slightly. It can also help with cleanliness, and the foreskin of the penis has been shown to harbor the HIV virus. So those are 3 reasons, positives for having a circumcision. Not enough, though, for us to say universally, yep, every boy needs to have that done. I will say about 80% of our office has circumcision. You won't make a bad decision. It is your choice on that. Breastfeeding. I know earlier in the lecture, the OB nurses have talked to you in detail about breastfeeding. I want to give you just some of my take-home points. When you're in the hospital, really utilize the OB nurses and the lactation consultants. They have years of experience and a wealth of knowledge to help you through those first couple rough days. Breastfeeding is truly an art. There's a spectrum. On one side, there's those moms who just do fantastic. The baby latches well, they produce plenty of milk, and everything's great. And there's the other extreme where it's a struggle, where moms just aren't producing enough milk, or their milk hasn't come in yet, or the baby's a terrible nurser, or having a problem with latch, and there's everything in between. We're here to help you, and so when you go home, you are not stuck. I always tell my moms, let me stress about it, and we're not going to let you fail. And I believe that because if we see that baby's losing weight, we'll bring you in every couple days to do a weight check if we need to make sure that your baby's going in the right direction. Our office has lactation that rotates through the office. A lot of other offices around town have that as well. And for those that don't, they should be able to get you in touch with a lactation consultant through the hospital to make sure that your questions are answered. So you're not stuck when you go home. And the first couple weeks, remember, is a learning process where you and the baby are both learning how this works here. Okay, so now let's shift over to the care of the newborn, some issues with that. So vitamin D supplement, that's a vitamin that is essential for bone development. And vitamin D, we get it through two sources. We get it through our diet and we get it through the sunlight. Well, the sunlight's the issue, especially in Michigan. It feels like for 4 months in the wintertime it's gray, right? And so by giving vitamin D supplement to the baby, we're able to ensure that they get enough of that vitamin D that they need as they're growing. It's very rare that a child would end up being vitamin D deficient, but by giving these supplemental drops for our nursing moms, it essentially eliminates that risk here. So most of the formulas we'll use are concentrated, so it's like 1 drop a day, and it's very easy to use. The take-home message with this too is you are going to forget a day or two. This just happens in life. Don't worry about it. This is a preventative thing. We tell our moms, do the best you can. Put it next to you. Put it in an area where you're nursing or a changing table or something that's going to jog your memory that you have to use this on a daily basis. But if you miss a day or two, it's not the biggest deal in the world. Also, we continue this as long as a mom is breastfeeding. Once you go on to formula or milk, whole milk, whatever that case is, then that's when we would stop those vitamin D drops. Okay, so care for males of the circumcision. Once the circumcision is done in the hospital, it usually takes about 10 minutes or so. And to back up, we use 2 forms of local anesthesia for this. We will do some lidocaine to numb the base of the penis, and then they'll use some sugar water to keep the babies comfortable. After the circ is done, the head of the penis is going to get kind of red and angry looking, and there's some swelling where it was clamped off. And then after 24 to 48 hours, you're going to see a yellow coating over the head of the penis. All of those things are normal. If I don't tell parents about that yellow coating, you're going to think it's getting infected, and that's not it. It's just strictly part of the healing process. So at the hospital, they'll show you, you'll use some Vaseline and some gauze pads to keep it clean and protected while it's healing. When do you stop that? It's usually 5 to 6 days out, and the telltale signs is when that redness has kind of milded out and that yellow coating is gone. Once those are established, you can stop the Vaseline and care for the penis like normal. Females, they have their own set of issues you have to be aware of. Hormonal changes take place in babies, mom's hormones that are inside of babies. So for young girls, we can see the vaginal labia will get swollen, red, warm. You can get some discharge out of the vaginal region, whether it's mucousy or bloody, and that is normal. It's like having a mini period. So I tell parents that because when you see a little blood in the baby's diaper, you're going to think, what in the world's going on here? And that can be just a normal phenomenon here. Also for boys and girls, it's not uncommon to get like a firm breast bud under their nipple, and that is estrogen changes that take place, and that's something that will go away with time as well. Especially for those little boys, we don't like the dads to worry that their boys are growing breasts. This is just a normal hormonal change, and it will get better. Umbilical cord, it usually falls off at about 2 weeks. All we have you do is keep it dry and clean while we're waiting for it to dry off or to fall off. A little tip also, that cord as it's drying up likes to stick to the normal skin of the abdomen. And so we try to keep it loose so that you can get air that circulates in there, because if not, it starts to break down and you get this really foul smell that takes place. So keeping it clear and clean is really the biggest take-home messages with that. Baths, we will do sponge baths until 2 things are accomplished. Once the cord has fell off, and for boys the circumcision's healed, then you can start doing sink like immersion baths. But in that prior to that, we'll just do sponge baths. Parents will ask me, how often should I bathe my baby? It's really up to you. We usually say, a couple times a week, every other day. It doesn't have to be a daily occurrence. Babies aren't getting that dirty, but they still will like dribble or drool with breast milk or formula, and it can get stuck in the folds and so forth. So just sponging them off is a good task. Bowel movements, there's a whole rainbow of colors, as I say, that we're going to see. The babies will start off with this black tarry substance called meconium, and then that will gradually pass, and then you go into transitional stools, and the color kind of goes from brown to green to yellow, and then the final product for breastfeeding is yellow and seedy, and that's normal. So parents will ask me, what exactly is it supposed to look like? Well, I don't know why we do this, but we always compare things to food. So the best way to describe breastfed stools is like mustard with seeds. That's exactly what it looks like. And that's normal. And I like to tell folks that as well, because they'll think, oh, my baby's having diarrhea, and it's not diarrhea. It's just normal breastfed stools. Babies are very efficient with processing breast milk, and so it's not uncommon to have little squirts nonstop throughout the day where you feel like, oh my goodness, I just changed this baby's diaper. That's normal. And that will change down the road. At 4 months, you might have a baby that doesn't poop but every 4 to 5 days. That's normal as well. What's most important when it comes to stools is the consistency. We don't like rock hard stools or constipation. Kids that are going and it's soft, that's the most important thing, whether it's daily or whether it's every other day. Early on, it's important that your baby's going and stooling daily in the first couple days of life, because it's an indication of how your breastfeeding is going. But after that, it's not as much a reflection of that. Sleeping, babies will sleep about 18 hours a day at first. And I always joke, at first you're going to say, does this kid ever wake up? And then after about 2 months, you're going to say, does this kid ever sleep? And this is normal. So a lot of our growth, or most of our growth, is done during sleep. So the babies come out and they have glucose stores on board that they're able to utilize. They are kind of go through, as I call, their newborn coma, and they're growing rapidly and recovering from the delivery process. So sleeping a lot is normal. There's a big difference between babies who eat well and then sleep and then eat well and sleep. That's normal, versus a baby that you can't wake up to feed. That's a problem. If that's the case, you need to talk to your pediatrician. I know earlier in the lecture, the OB nurses also talked about postpartum depression a lot. So I won't go in detail about that, but a couple take-home points. In our office, in most pediatric offices, they'll do what's called an Edinburgh screen. An Edinburgh screen is a postpartum depression test, and it will ask you a series of questions to see how you're doing. If you score positive on that, we'll talk to you about getting help through your primary doctor, or through your obstetrician, or getting counseling, those type of things. The big take-home message I wanted to mention is that there's a big difference to me between postpartum depression and baby blues. I will tell you that I would say 90% of moms have some element of baby blues. And the difference with that is baby blues are just episodic periods where you're just crying or emotional. Postpartum depression is where functionally you just struggle and you're having bad thoughts and so forth. With baby blues, it is temporary, and it has to do with the fact that we have a child that's all-encompassing, we're not getting any sleep, and we have hormones rushing through us. The combination of that makes it very likely that you're going to have some teary-eyed episodes, and that's normal. So the main take-home message is, if that happens, give yourself a break. Things that can be therapeutic. Go out and go for a nice long walk if it's a beautiful day. Utilize your spouse or your family members to help you so that you can get out of the house, or you can get some fresh air. That can sometimes make all the difference in the world. Or even if you need to nap during the day, do it. If the baby's sleeping, you get your sleep. The dishes can wait and other things can wait. What's most important is you take care of your own health. So some common newborn issues that we see. Hiccups, very, very common. And a lot of you moms have felt your baby hiccuping inside of you. Well, that continues once the baby's born. And so hiccups can be very pronounced, and they can be very frequent because they're usually established by feeding. So you feed and it triggers it, and then sometimes feeding actually can stop them as well. They're harmless, it's nothing to worry about, and it will get better as the child gets older. Nasal congestion, I always say that this is the norm in the newborn period. There's a variety of reasons why babies can be congested. It can be that they have a cold, it can be that they refluxed some breast milk or formula, it can be environmental exposures, not necessarily allergies, but like pollens and stuff blowing around, or the forced air furnace in the wintertime. The baby's nasal passageway is so tiny, it's really small. And so anything that gets in there is going to make it sound worse than it really is. If your child, though, is struggling to breathe, like with feeding, or is really congested, what do we recommend? We have you use the bulb suction or the nose Frida. And a little tip for you is to block the other nostril when you do it, so that you create a vacuum to get as much out as you can. If you just put it in there and suction, if you're not directly up against something, it's going to just suck air out of the other nasal passageway. So a little tip for you there as well. Diaper rashes, very common in the newborn period, partially what we discussed because they're having such frequent stools. And you can be the best parent in the world, but it's so hard to keep up with it sometimes. So as soon as you start to see that your baby's bottom is getting red or raw, that's the time to start using a barrier cream such as a Desitin or a zinc oxide product to help keep it clean and to protect that skin. It's the stools that are acidic and they literally burn the skin. So if we can keep the stools and the diapers clean and use a barrier cream, that's usually all you need to do. Crying, I know it's a shock to most people, but crying is normal in babies. And they're going to cry a lot. Most of the time it's for a need. It's either they're hungry or they have a dirty diaper, or they're sleepy, or there's a variety of reasons for it. What I want to stress, though, is that especially in the evening, some kids will have just their fussy periods where they just kind of need to let it out for whatever reason. As a parent, what you have to do is reflect on, have I done everything in my care? Have I changed the baby's diaper? Have I fed them? Is there something that's bothering the baby? If the answer to that is no, then it may just be a lot of rocking and calming in the evenings as the baby settles down. On the flip side, if a baby is fussy all day long, all the time, that's not normal. And that's when you need to talk to your pediatrician about that. Blocked tear ducts are another thing that we'll see with babies that are very common. So there's a duct that connects from the eye to the nose, and that's why when you cry, you sniffle. Those are tears pouring into your nose. Well, those ducts get blocked in babies because of the birth process or because they're just so microscopic and they may have a cold or some swelling, it blocks it off, and they'll get tears that stagnate in the eyes, and then the surface bacteria get in there and it goops up. This is a harmless process. It's not a pink eye. So what we have parents do for that is just wipe away the discharge and use your little finger and just go right in the corner here and kind of massage in that area, and it helps to push that down and hopefully break open that duct so that it will drain effectively. It can last a day, a week, months, and then eventually it just goes away, and it's a harmless thing. Last thing to talk about is newborn safety. Car seats. We recommend, obviously, the babies are rear facing in the back seat of the car, hopefully in the middle of the car if it's feasible. Spectrum does a good job of doing car seat checks, and also they offer a class that you can do if you want more information on that. A lot of the local fire departments will do car seat checks as well. The key with the car seat is making sure the base is in there tight and level, and sometimes it means building up that base if your car seat is angled a little bit with either a blanket or a piece of foam to allow it to sit level, and getting in there and putting your knee and your weight on there when you pull the latch system to keep that base in there tight. So those are just some take homes with that. Babies should sleep on their back. We talk about good crib safety, either a crib or a bassinet, what they're wearing, a light blanket, and nothing else in the crib. No stuffed animals, no bumpers, no pillows, any of that stuff. We can try to keep that out of there. The reason we want kids on their back is so that they wouldn't asphyxiate or get stuck into something where they couldn't breathe. And that's why when babies were belly sleepers, the incidence of SIDS, or sudden infant death syndrome, was higher in that age, in that period. And it has plummeted since we've gone to the Back to Sleep campaign. So really important. Other things that can cause SIDS is being around cigarette smoke. And smoking in general has a lot of harmful effects for the baby. In addition to SIDS, it can increase illnesses in general, ear infections, asthma, and so forth. So if you are a smoking parent, we talk about smoking outside your house and not in the car. If you have any family members that smoke, have them just do the same. And then if you can, we try to get you to quit. If you can't, wear a smoking jacket or something that can get the kind of the odor and stuff on that you can remove, so the baby's not inhaling that secondhand smoke. And the final message that I'll leave you with is about a syndrome called shaken baby syndrome. And shaken baby syndrome is where a baby has been rapidly shook and that the brain jostles around in the skull and it tears blood vessels, and it's a devastating condition. I've seen several of these kids years ago when I was a resident, and it's just heartbreaking. You have a perfectly healthy baby who then has lots of neurologic and eye problems after that. This is an avoidable situation, and this take-home message is that babies are frustrating, and they are all-encompassing, as I mentioned, and you can see where parents don't mean to do this, but what happens is they're frustrated and they pick the child up. Why won't this kid stop crying? And that's all it takes. So never let it get to that point. If you feel your emotions are building up or you feel your level of frustration is building, put the child in the crib and walk away. Babies don't get hurt by crying. So utilize your spouses, as we mentioned, utilize your family members, and give yourself a break, because they can be very difficult in that early time period. That concludes my component to this lecture. I hope that is helpful. Good luck to everybody, and have a safe and healthy pregnancy.
Hi everyone, I'm Dr. Rebecca Lax from Grand Rapids Women's Health. Today I'm going to talk to you about car seat safety. It has been found that 4 out of 5 car seats are actually improperly installed. So today I'm going to review some highlights and tips to make sure that your car seat is installed correctly. From the infant stage to 2 years of age, it has been recommended that the child ride in the back seat of the car in a rear-facing position. You can either use an infant carrier, as seen here, or a convertible car seat. Using an infant carrier, you want to make sure that the carrier itself is installed securely within the base. The base is then installed to the seat through the latch system, or using the seat belt, lap belt, if you do not have a base for your car seat carrier. You want to be sure that the infant is securely strapped within the harness belt system. So looking here, the 2 shoulder straps, you want to make sure the level of the shoulders are just below. You want to be sure that the chest clip, which is seen here, is at the level of the armpits or the nipple line. You don't want it any lower. It is also important, especially in the winter months, that we do not dress our infants in multiple layers of clothing. You don't want to put a heavy coat or jacket on your baby and then put them in their car seat. You really just want a single layer of clothing between the car seat straps and your infant. They do make covers that fit securely along the edges of the car seat, which are safe as long as they're outside of the belt harness system. Along the same lines, it's very important not to use any sort of toys or dangling objects from the infant carrier handle. In the event of a car crash, these could become dislodged and act as projectiles. It is also important that other items within your car are securely fastened, such as groceries, bags, or purses. That's it for car seat safety. If you have any questions, please don't hesitate to call us or email us. Thanks.
I want to close by thanking all of you for taking the time to review this video. I hope that it's been helpful. On behalf of all of the doctors and staff at Grand Rapids Women's Health, I want to thank you from the bottom of my heart for trusting us with the care of you and your baby during this pregnancy. Please let us know if there's anything that we can do to give you any reassurance or added information during this very special time in your lives. If there's anything new that comes up with the COVID concerns, please call us. I know that these are unprecedented times and we are all a little bit anxious, but I want to continue to make this just a very special time in your lives, and thanks for trusting us.